Welcome, everybody. I'm Dr. Scott Benjamin, and I appreciate the opportunity to have the ability to speak to you tonight on a very important topic that's oftentimes overlooked in dentistry on how do we manage our surgical sites, wounds, and lesions in the oral cavity. On way of disclosures, I'm showing some of the things I'm involved in here, with the idea that my expertise and what I'm very well known for is the work I do in the laser world, as you can see from this. I'm not receiving any honorarium at all for this presentation, and everything you're going to hear me say tonight is 100% my own personal opinion, and I'm not here to represent any of the schools I teach at, or any company, or any organization at all. As I mentioned, I have a very weird background. As a matter of fact, this morning I was actually teaching a laser course at the University of Buffalo Dental School. And I'm on faculty of several dental schools with the idea that my role is to help getting laser education into the core of the curriculum now in many dental schools. And as you can see that I have a fairly diverse background. I'm also the past chair of the ADEA Special Interest Group on lasers and dentistry, and have worked with a variety of companies through the years. So what we're going to talk today is something that we in dentistry tend to not to think of, but we're going to talk about wound dressings. And, one of the comments when I talk to a lot of our colleagues about this is that, well, gee, I don't wound anybody. Well, all surgical sites are considered a wound. And by definition, it's basically anytime the tissue is not intact. And with the idea that when we deal in the oral cavity, we have a whole variety of things that we have to take into considerations that do not really affect many other areas of the body. So again, anytime we're making any sort of incision, doing any sort of procedure, extracting a tooth, we are creating a surgical wound, and it needs to be appropriately addressed and maintained. And maintaining this is an extremely complicated process. And it's the foundation in systemic health care. Wound dressing is considered the standard of care, that all wounds must be dressed as part of the procedure itself. In dentistry, it's been sort of been pushed over because of the complexity of what we're dealing with. To get the outcomes that we're looking for really has a requirement that we try to control the bacterial activity, control the inflammation, and try to get the patient to heal as quickly as possible with the least amount of discomfort. And as you can see here, of wound healing is an extremely complicated process that we need to address. Now, in turn, again, there is no such thing as a tricorder. As a kid growing up, we used to watch the Star Trek, and you always saw Bones waving a device over the patient and coming up, and instantly they was cured, and instantly the patient felt better and everything else. Well, we know that isn't reality. And again, there is no such thing as a tricorder or even a magic wand. One of the problems we have today is we live in a world of much misinformation or disinformation, that we are being told things by sales reps and a variety of things that just don't make a lot of sense. And what we're going to talk about today almost seems along that pathway. Managing wounds and lesions, with the idea that when we start talking about this, it almost sounds like snake oil. Oh, we're going to be using light energy. We're going to be using basically materials to help heal the patient that can be ingested, that are non-toxic, and a variety of things along that line. So to start off, I want to talk a little bit about a topic that many of you may not be familiar with, and that is photobiomodulation. Photobiomodulation is the use of low levels of light energy to either stimulate or to inhibit a tissue response. And again, the goal of this is to control inflammation, which is a primary component of healing, and manage the edema and enhance the repair while reducing pain. And so this becomes an important part of what we are trying to accomplish as we are treating wounds, areas that our surgical sites that we have created by trying to get our patients into a healthier situation. When we look at the applications that really apply to how we're going to use photobiomodulation, it's a matter of, you look at this chart that was put together by Dr. Praveen Irani at the University of Buffalo. What are the primary goals, no matter what the procedure is to reduce pain, control inflammation, and in many situations, enhance healing. So as the light energy goes in, hits the mitochondria within the cell, we see this type of response occurring. And the goal here is, how do we heal our patients? How do we get the cells to turn over as quickly as possible to get our patients out of discomfort, to control the inflammatory response, and get them back to intact tissue as quickly as possible? A demonstration of the efficacy of photobiomodulation, which in the past was known as low-level light therapy, as you can see in this slide here. There was some fibroblasts that were distributed on some petri dishes in the study. One, the control was non-irradiated, and on the other side, it was irradiated with laser of a 10,064 nanometer wavelength for a period of 2 minutes. And you notice that the amount of fibroblasts that have now regenerated and turned over are significantly better here after they've been treated with photobiomodulation than the control that was not receiving any light therapy at all. The role of light therapy is literally to go in and to energize the cell to perform in the manner that it was really designed to be doing. An example of the efficacy of how this works outside of it, this is a colleague of mine who, as I make a joke, mistook his finger for a 2x4 and hit it with a circular saw. On the way to the hospital, he was actually treating himself with a portable photobiomodulation unit. This is what the wound looked like the next day after being stitched up. Here's what it looked like at a week later, and here it is at 6 weeks. This is the type of healing that we want to see. We don't want to see the type of accident that occurred here, but be able to get the patient back to a normal condition as quickly as possible. This is an extremely important concept. As we know, when we're dealing in the oral cavity, we're dealing in a dirty field. We have a variety of things we have to address. And PBM, which is the abbreviation for photobiomodulation, is a concept and a technology that we use routinely relating to our extractions, our osteotomy sites, our implants, to control the inflammatory response that is going on in the oral cavity. Studies are actually showing that 90% of all implants that are in patients' mouth today have some sort of inflammatory component around them. So in my practice, we're actually using PBM as a prophylactic procedure around all implants at every one of our hygiene visits. And the idea of using light energy has been shown not only to help in the healing, but some studies have recently shown that it's helping significantly in all forms of healthcare. And this is a study that was published in Oral Oncology that actually showed that the progression-free survival of patients that were being treated for head and neck cancer had an increase in their longevity and in that type of a scenario. So the idea of using something that on the surface appears to be snake oil or smoke and mirrors, by giving the cells the energy that they need, we then in turn can accomplish a healing response. And again, why is this occurring in this situation? Well, a study that's being done at the University of Pittsburgh, Annette Quinn in her oral oncology study on oral mucositis has actually shown that by using photobiomodulation on, again, the wound here of oral mucositis, that after 3 treatments, they got the patient back to a stage of being comfortable. And again, so is photobiomodulation increasing the lifespan of these patients, or is it giving them a quality of life and allowing them to live in a scenario that enables them to complete their treatment appropriately and to be able to ingest food appropriately and to have the appropriate nutrition to move forward? And again, the process of performing photobiomodulation is controlling the dose of the light energy going into the cell. The right amount of energy will stimulate a response. An excessive amount of energy can actually inhibit a response. So depending on what our treatment goal is using the light therapy appropriately. And applying the energy is so simple. Here is a picture of a patient who's being treated at St. Jude's Hospital. This is a 3-year-old that is self-administering the light therapy under the supervision of the oncology nurse that's overseeing his treatment, with the idea that it is painless and at the same time, it is simple and easy to acquire. So again, looking at these type of processes and what it can do to improve the quality of life and enhance the outcome for our patients is significant. When we start looking at what the effects are, basically, as I refer to with my patients, is we're taking the cell out of oxidative stress. We're putting energy into it to allow it to have the appropriate amount of reactive oxygen species, and at the same time allowing the stimulation of various growth factors that have a positive effect on cell growth and regeneration. And positive effects has been shown on these cells that have a lot to do with what we're doing in the oral health environment. Odontoblasts, osteoblasts, keratinocytes, endothelial cells, fibroblasts, macrophages, neutrophils, 2 primary components of the blood that literally lead to having a better outcome and an enhanced healing. So the idea of knowing that we have light therapy that can help manage a wound becomes a significant part of what we're able to do. So as we look at what are the classifications of surgical sites, and as you read through these, you're going to actually see that where we are in the oral cavity, we're dealing in a dirty and infected wound site because of the flora of the oral cavity. Because there's no way in the world that we can eliminate the bacteria that are constantly bathing our surgical sites, that we have to be considered, as all of our wounds are considered in our surgery, are class 4 infected wounds. And so we need to be able to treat them appropriately. But treating the surgical wounds is an extremely complex situation. There are 3 overlapping phases of it. Inflammation, which we're very aware of, which is one of the things that causes the pain. Proliferation, where the cells are now starting to regenerate, and then the remodeling of the tissue. And as we know, a bacterial infection increases the inflammatory process, but it also delays healing. Now, one of the things that's been shown in multiple studies that the use of essential oils play a significant role in reducing the microbes that are in the area of the wound itself. And in the oral cavity, we have to be very concerned about the constant bathing that is going on with the saliva, the bacteria flora in the mouth, and the functionality that we need to be doing. So as we look at the process of wound healing, in the inflammatory stage, what is going on? The exposed tissue is now going through and being exposed to all of this. The neutrophils, which are the first cells that appear, are there to basically try to systemically clean out the wound from an internal point of view. And again, manage the bacteria that are in the process. And the idea, they want to provide the best possible environment for wound healing. Again, having the macrophages and stimulating their capacity, in turn, allows us to hit the phagocytotic nature of the bacteria and getting rid of that. And understanding that, as we're very aware of in our practices, that to get complete hemostasis and to control the inflammatory response takes up to 72 hours for it to completely finish. So one of the goals that we have to have is, how do we treat our patients on a regular basis to get the outcomes that we're really truly looking for? And understanding that this inflammatory phase is what causes the most amount of pain and discomfort right from the very beginning. So being able to treat this with agents in the oral cavity as well as with photobiomodulation really can help move things in the right direction. During the proliferative stage, what happens is, again, we now start having the fibroblasts, the keratinocytes, the endothelial cells are now going through their process of turning over, trying to really create a very fragile matrix that in turn is going to enable the healing to occur on a proper basis. There are multiple growth factors and cytokines that are involved that need to participate in this phase. And so what we want to accomplish is to be able to allow these cells to do their job to function properly, to make sure that we get the collagen and the elastins that are forming the granulation tissue to in turn meet the goals that we're trying to. And then during the remodeling phase, we're trying to take our immature collagen that is part of the granulation tissue and develop it into mature type 1 collagen and get the outcomes that we're looking for. And again, having the balance between the apoptosis and the production of new cells is keeping this in the appropriate balance of having things turn over and regenerate on an appropriate manner. As you can see, everything I'm alluding to in these slides comes right out of the medical journals. And looking at what we are trying to accomplish becomes very important. So when we're in the oral cavity, we have a lot of things that we have to contend with. And one of the primary things we have to contend with is the bacteria flora of the oral cavity. We know that that constant bathing of saliva over the surgical site that we've created or what we are trying to heal up becomes an important problem of being able to control the bacterial activity in that area. The different types of tissue that we have to deal with the idea that there is, we have, both keratinized tissue and mucosal tissue. And the fact that the oral cavity is constantly working and functioning. With speaking, eating, drinking, breathing are all movements that need to be made accordingly. And trying to have all of this being done and applying medications that are non-cytotoxic that can be ingested and will not damage, the rest of the GI tract becomes very important. So as we're looking at these type of concepts, it becomes very important that we understand that we're trying to treat a myriad of bacteria and trying to keep that wound as clean as we possibly can, controlling the inflammatory response, and making the patient as comfortable during this healing process as we possibly can. And again, one of the things as we look at with the basic principles of proper surgical procedures is applying wound dressings that are antimicrobial and relieve pain. This is the goal that we're really truly after. And again, in the oral cavity, we can't apply bandages for the most part to our soft tissue. Possibly a periopac around a periodontal surgery is a possibility, but other than that, it's really limited in what we're doing. And we need to make sure that we understand the anatomical functions of the tissue we're treating, as well as what are the movements and the actions that tissue will be taking during that healing phase. So looking at what are the primary things that we can use in the oral cavity comes down to basically ointments and oils and things along that line that lead us to get the outcomes that we're looking for. Very, very, very critical that as we look at these things, we start evaluating, are they cytotoxic? Will they give us the outcomes that we're looking for? Because this becomes an important aspect. When we look at essential oils formulations have been shown to be relatively safe with good biocompatibility and have great pharmacological potential. The structure of the essential oils, which is basically oil and water, can really facilitate the healing process that's going on and incorporate the hydrophilic nature that we need to have on the target tissue of the oral cavity. So looking at these essential oils, where do we start? Well, the oil of thyme it has good potential to being incorporated because, again, it can create an antibacterial and a permeable films for a wound dressing. The antimicrobial effect and the antioxidant and the anti-inflammatory component of the oil of thyme really makes it beneficial to give us the potential to getting the growth stimulation that we're looking for. And this is very, very important. The effect of the oil at time that is shown on various microbes as you're treating, again, the viruses, herpes simplex, influenza, strep mutans, and gram-negative bacteria are very important to what we're doing within dentistry. And these have very synergistic effects if they're used in combination with other oils such as cinnamon. And so looking at this being able to be antibacterial, antifungal, and literally giving us the outcomes with a very low amount of toxicity, being able to be ingested. Because anything that we place in the oral cavity as a dressing or as a wound is something that has to be biocompatible, that can be ingested or eventually will be ingested as part of the process. Very important that we look at things from that point of view. We look at another essential oil, the oil of cinnamon. It has been shown to have a synergistic effect with the oil of thyme and the oil of cloves, which is we're very familiar with our eugenol. And it's been shown to actually have a better antimicrobial activity than things like tetracycline, ampicillin, and various antibiotics along that line. And again, looking at the same type of bacterium that it actually has the ability to be effective on, because as well as the viruses, makes this type of a process very, very, very important to us. And so it's combining these together to get the outcomes that we're showing. And again, looking at some of the controlled studies out there that are showing that, again, the application of cinnamon promotes the granulation tissue formation, basic of the proliferation stage of healing, balances the inflammatory infiltrates, and it consequently accelerates the healing process. And again, gives us a faster transition to get from the inflammatory stage into the proliferation stage. And again, it's helping by upregulating various types of growth factors and increasing that cell, the cell proliferation and the collagen synthesis that we're truly looking for. And so looking at combining these oils together gives us the outcomes that we're leading in the right way. Control studies have actually shown that the topical administration of cinnamon in particular has remarkably shortened that inflammatory phase and therefore moves us quicker into the secondary field than increase the healing, taking us out of the painful stage and now into the regeneration stages, which is where we want to be, with the reepithelialization and the keratins now being appropriately synthesized by the body to give us the effects that we're looking for. And so this becomes an extremely important concept. Looking at some studies that have been put out there, comparing the control versus the 2% and 4% oil of cinnamon being applied to the wound sites. As you can see here at day 4, there was a significant decrease in the wound area. At day 8, it further increased. By day 12 and 16, it was basically all gone. But you can see that, again, a 2% and a 4%, both of those were significantly better, decreasing the size of that wound in a very short amount of time. When we start looking at the bacteria count, we see the same thing happening in the same realm, which makes perfect sense because we know the number one thing that impedes wound regeneration is bacteria infiltration. So having something that in turn can keep the bacteria count down then enhances the ability for the wound to go through the appropriate healing process. This is an extremely important concept that we really need to be looking at and understanding the role of how we move this in the right direction. Promoting the reepithelialization of wounds. And this is 2 weeks after the treatment had been done. Look at the difference between the control on the left-hand column compared to the 2% in the middle and the 4% on the right. And looking at the magnification and how much healthier that tissue looks and how getting it to the right stage. And again, and that's what we're trying to do is get that regeneration of tissue to be able to give us the outcomes that we're looking for. And again, significantly increasing the keratin formation that goes on is also an important concept. Looking at the difference here between, again, the control, the 2%, and the 4%. These are from the same study, showing that we're getting a better healing response by using this as one of our wound dressings. And we're all very familiar with the fact that, cinnamon is a non-toxic. It's actually part of a part of our diet, with cinnamon rolls and a variety of things that we're routinely ingesting as part of our daily diet. So we're using materials that become, that we are very familiar with the biocompatibility of it. Another essential oil that we're very aware of in dentistry is the oil of cloves. As we know, this is the primary component of our eugenol. And again, this also has been shown to have a synergistic effect on our antiviral drugs, such as acyclovir. So with a relatively low toxicity here, and again, noticing that we're treating everything from a fungal infection to various, viruses to various antibiotics, with the idea of doing that. So the role of the essential oils is basically to give us an antimicrobial effect in a non-toxic manner, with the ability to have something that can be appropriately ingested into the body. So having a dressing that is drug-free and biocompatible becomes very, very important. Now, one of the things we need to be doing is also controlling the discomfort related to our surgical procedures. And most of us are very familiar with the aloe plant, the primary ingredient, the sunburn cream, to reduce the pain associated with that sort of trauma. The role of Ace Mannan is to stimulate the macrophagic activity. The idea of activate the macrophagic response to literally help take the pain away. So we have an increase in the cytokines and the chemokines to give us the responses that we're looking for. So as we start looking at the biological processes that go on, Ace Mannan also assists in treating, again, the phagocytotic ability of the cell turnover. So being able to affect the cell membrane and giving us that type of response to stimulate all of this activity going on within the cell itself further exacerbates the goal that we're after. So trying to get to the outcome becomes very important. And Ace Mannan has been shown, which is again the primary component of the aloe vera gel, has been shown to literally increase fibroblastic activity at a 1-week period. And so it plays a very significant role in the healing process via, again, the increase in fibroblastic activity, upregulating, and again, getting the type of type 1 collagen to actually progress significantly. And at concentrations of anywhere between 2 and 16 milligrams per milliliter has significantly induces this proliferation to occur. So wound healing and animals receiving that have been shown to have a significant better response than the other groups that are out there. And so part of what we really want to be doing here is coming up with a material that enables us to have all of these components put together. Looking at, again, the effect on, again, it significantly increase the ligaments of the cells of the periodontal ligament, upregulating the growth differentials and getting that type 1 collagen to perform, as well as the alkaline phosphatate to actually occur. And the whole idea, Ace Mannan also accelerates new alveolar bone growth. I'm using this routinely in my practice, not only in furcation involvements and periodontal treatment, but also as part of my implant surgery. Because if we can increase the acceleration of new bone formation, means that in turn we can be a little bit more aggressive on what we're doing as far as a time schedule to give us the outcomes that we're looking for. Some studies have shown on wound healing that there's a significant difference on allowing, again, burns to heal faster again. And you're comparing it to just an occlusal type of gauze dressing, Silvadene, which has always been the mainstay of treatment for antimicrobial gels. Again, the aspirin cream. Notice that the one that has had the greatest effect has been the Ace-Mannan. It's the only one that showed a significant difference that was found in the animals that were treated with this, which healed on the average of about 30 days. And so again, looking at the studies and what they mean to how do we then apply this into dentistry becomes very, very important. We look at now what we're trying to do with induced tooth socket healing. And again, CBCTs have actually shown that that there is an increase at 3, 6, and 12 months, looking at again where third molars have been extracted. And this was again looking at a variety of sites. And going back, and the outcome of this study was actually showing that the 50 milligram Ace-Mannan group had a significantly greater reduction in socket volume. In other words, the regeneration of the bone in the extraction site at all times postoperatively. So making this a routine part of your extraction protocol makes logical sense to give us the outcomes that we're looking for. We routinely treat every one of our extractions and every open wound in the mouth with a gel that contains essential oils and Ace-Mannan for very specifically these type of reasons. And again, looking at it around implants, it's been shown that the dimension and reduction of was significantly smaller on areas that were treated with the Ace-Mannan as part of the implant placement. So again, looking at comparative with using just bone grafting by itself or bone grafting using bovine bone with a Ace-Mannan containing material gave a significant improvement on the outcomes of where we were at that point. So where are we? How do we then incorporate this into dentistry? When I first heard of a product being available to us, I thought of it was going to be nothing more than snake oil. And when I was introduced to the product called OraSoothe Socket Gel, which is basically, if you see the components of this, is just what we just talked about. And it's a matter of, again, taking something that's all natural food ingredients and then in turn adding the xylitol for a little bit of a sweetener to it, which we know xylitol also has an anti-cariogenic effect. We have something that is non-toxic and is drug-free that we can use that actually has FDA 510K marketing clearance to be used for oral wounds. This has both a gel that we use routinely and to apply directly to any sort of wound that we have in the mouth, whether in an extraction, whether it's a frenectomy, whether it's any other type of surgical site, whether it's an osteotomy or an implant placement. And then there is a mouth rinse that basically is a watered down version. The original formulation of this, I believe, was designed for pharyngeal cancer patients to literally take the oral rinse, swish it around, and then swallow it to relieve the discomfort of the pharynx, as well as to reduce the microbes that are on that cannot be treated any other way. And so looking at the value of combining all of this together has had a really good impact in reducing the need for narcotics. One study actually showed that, again, we're using this on an immediate denture, showed that the reduction in the need for a narcotic and pain medication was significantly reduced. As you can see, at 10 minutes was less than half the amount of pain than doing anything else. So the gel provided a statistically different, significant release in what's going on and then being provided, than just using a narcotic by itself. In my practice, because of these things, I haven't prescribed a narcotic in decades because I no longer have a need to. Because again, being able to control it with something that is non-toxic, non-habit forming, that can be adjusted, becomes a very valuable thing than what we're doing. The fact that it also decreases the sodium concentration, means that the nerve transmission that is going on that causes pain over this period of time, you can see how it was significantly reduced. So again, what is this material? I mean, this is the only thing that I know of in dentistry today that combines all the things that the studies are showing us to give us the outcomes that we're looking for. So again, what is this Orasue socket gel? It's a wound dressing that with the goal of basically creating an environment that helps stimulate the healing to occur. How we use it in my practice is anytime I have an open wound, we're applying this gel to the wound directly as part of the treatment, going into the extraction site. I actually am mixing it with my my material for my bone grafting, with the idea that looking at the study showing how it stimulates the bone turnover is making. And so we perform it in the office and then give it to the patients to take home. Now, the instructions I give them, I said, I would like you to use it at least 4 times a day, but more importantly, anytime you're thinking about the treated area, I want you to apply some. With the idea, if it is not bothering them, that means the healing process is going on as expected. If it's drawing their attention, it means that some form of treatment needs to be made. You know, they can place it directly in their denture, squirt it directly on the wound. And again, my instructions are take it, throw it into a small thing like a small end of a shot glass, apply it with a Q-tip, your finger, your toothbrush, or if you think you're dexterous enough to actually try to squirt it into the extraction site, you can do that, but most patients don't have that ability. Now, when we compare the antimicrobial effect of the formulation that they have here, comparing it to chlorhexidine, it's actually showing that it's actually got a better antimicrobial effect on the things that pertain to us within dentistry itself than chlorhexidine, looking at a 30-second and a 5-minute outlay. Significantly better improvement. Now, again, we stopped using chlorhexidine in my practice a long time ago when you start reading the studies that are showing that chlorhexidine by itself is actually in turn destroying the exact cells that we're trying to grow. At a concentration of 0.00009% has been shown to be extremely cytotoxic to gingival fibroblasts. So why in the world are we actually putting this on a wound and having patients rinse with this after we've done treatment? It's almost completely counterindicated because of the effect that it has on this. It's a great antimicrobial agent, but it's also very cytotoxic to the cells we're trying to generate at the same time. What's very intriguing, the U.S. Air Force actually did a study on this, and they gave it to 246 individuals after various types of procedures at a variety of different sites scattered around their bases. And the rating they gave it was an excellent rating, one of the highest ratings they've ever given any product ever because of the efficacy that this had. And so again, looking at the studies here, we now have a system that literally can go in and give us the outcomes that we're looking for. On the beautiful side of this, from the practice management point of view, there is actually a reimbursement code for drugs or medication dispensed in the office for at-home use, which prescribes the use of this. The National Dental Advisory Service is recommending a fee somewhere between $27 and $92. In my practice, we're marking this up. We're paying, I want to believe, somewhere around the neighborhood of about $15 a syringe for it. And I believe we're charging our patients, I want to say $17 to $19 for it, because my number one goal is if I can get rid of their post-op discomfort, I can get rid of the follow-up appointments. Getting rid of the follow-up appointments, I've just, by the cost of just turning the room over to say nothing about my time, I saved my practice $30. And so understanding that as we're doing these things, I'm more willing to give this away to my patients than I am actually to charge for it. Because again, I don't want the post-op complications. when the idea is if I can now avoid all of this, so with a simple matter of applying medications such as this, they give me the outcome, it becomes very, very important to us. So again, looking at the thing is, what are the benefits of this type of a medication? We get the analgesia from it without numbing it. It helps with the contamination. It helps with the healing. It is designed to be used both in the office and sent home with the patient. And the most important thing to me from a selfish point of view, it reduces my unproductive chair time. My patients are more comfortable, and I have better healing, and I have a significantly less post-procedural complications. So again, it's one of the things that we need to be looking at. Where do we want to apply some of these type of conditions and treatments with the photobiomodulation using a material like this? Anytime there's a cause for an inflammatory response, which means all surgical procedures, whether it's an extraction, whether it's a laser procedure, whether it's a graft procedure, whether again we're doing an endodontic apical surgery, restorative procedures where we've had to injure the gingival tissue because of the subgingival nature, and becomes part of our scaling and root planing scenario, with the idea that because of the way this promotes PDL regeneration, at the very end of our laser-assisted scaling and root planing, we're applying a very thin layer of this right along the gingival margin. And by doing that, we've now created an environment to help protect that area from getting reinfected, but at the same time promoting the exact type of health that we need. Now, very important, how do we talk to our patients about photobiomodulation and wound dressing? And this is something that becomes very, very important to us. Is accurate communication is extremely important. I'm a big fan of the Far Side cartoon. I'm just sad that Gary Larson is not doing those anymore. And this animal is going to be very upset when he finds out when he goes to the vet that he's not going to get tutored. With the idea that having the patients understand what we're trying to do and get the right outcome becomes very important to us. So proper communication is extremely, extremely important. I'm a very firm believer of under-promising and over-delivery. I found very early in my career that telling patients a variety of things, what we say to them and what they hear are two completely different scenarios. We never tell a patient that these treatments are going to reduce pain, because what our patients hear is they hear that it's going to completely eliminate pain. And so we always talk to our patients of, we're doing these procedures to help promote the healing process and to help control the inflammation that is going to occur. You are going to have inflammation. There is going to be some discomfort. And the role of these devices and these technologies is to give us the outcomes that we're truly looking for. This is extremely important. Patient communication is a huge part of the healing process. To have the patient understand that we've done some very sophisticated procedures on them, and as dentists, we've done a very good job of making very complicated procedures to our patients to seem very simple and mundane. Being able to do a lot of the things we can do with lasers in our laser surgery today. We've greatly simplified a lot of surgical procedures by using the right devices in the right places. And then in turn, using the photobiomodulation, applying an ointment like the socket gel to it, to in turn give us the outcomes that we're looking for. That becomes very, very important. So in conclusion, because I purposely wanted to leave a fair amount of time for question and answers, one of my favorite quotes of all time: it's not the strongest or the smartest that are going to succeed. It's those of us that are most responsive to change. Today, dentistry has significantly improved to where it was when I graduated 40 plus years ago from dental school. And taking advantage of these new technologies, these new modalities, and these new ways we have to treat patients become extremely important. So what I want to do at this point is I want to open up the question and answers. So again, we've got a couple of those in the Q&A. Anything that you need or any question you have, put in there and we will try to answer them. The first question that I see here is, do I recommend patients applying essential oils? And the answer is how often? Yes, but I wanted to make sure that as we're applying essential oil, that we're doing it in concentrations that are appropriate, which is why using something that is FDA, because they received FDA marketing clearance, becomes very important. And as I mentioned during the presentation, ideally we want a minimum of 4 times a day, but more importantly, I tell the patients, anytime you think about it, I really want you to apply the socket gel to that, because again, I want you to heal appropriately at that time. And again, with it, and the next question is how long does it stay on the tissue after you apply something like the socket gel? Well, then with the idea of having the patient in turn apply it, and as long as they're not in discomfort, I'm in no big hurry. So again, it stays there for a period of time. The OraSoothe rinse is very tenacious. It's very sticky. I don't use it as an in-office intraoral rinse because I find that I'm sliding off the tissue too easily. However, I'm having them use it at home where it stays there significantly longer than other mouth rinses. And I have them apply the gel, and because it's non-toxic, with having the patient apply as much as they feel is appropriate to them becomes very, very important. So am I concerned about them overdoing it? And the answer is no, not a bit. And with the idea is I want to have my patients out of discomfort. I have never had any other product that I've ever used in my office that patients will call back and say, can I come in and get more of this? Because they've seen the value of what it's to preach to them. And does the Oragel what does it taste like? It's got a very strong cinnamon aroma to it because of this oil of cinnamon, which is the one contraindication. If the patient has a known cinnamon oil allergy, I would not recommend using something like socket gel because of the concentration. The concentration of cinnamon in it is exactly the same as the concentration of cinnamon in ketchup. But the fact that I want them to apply it consistently, if a patient says they have a cinnamon oil allergy, which affects a small part of the population, but it is an allergy that we need to be aware of, and you should be asking for things like that on your health histories to make people aware of the sensitivity that's. And can this gel be in approaching it that way? Is it approved for children? It's approved for all wounds. Now, again, sometimes children don't like the taste of cinnamon, and so it's one of the things that when a tooth has been exfoliated, it would be a very good thing to apply to it to give them that relief. If a child enjoys the taste of cinnamon, it should work very well for them. And one other question I got, can this be used in root canals? Well, not injecting it into the canal itself, but again, in turn, if you're doing an apical procedure and those type of things, it is an ideal medicament to use after we've lavaged out the destruction that's there and done our apical treatment, to actually place this inside of the cavity and then suture it in place. It can be used that way. And then one of the next questions is, how long are our PBM treatments? Well, it depends on the therapy that we're doing. When I'm doing it for maintenance of our implants, we're applying it for 30 seconds on the facial aspect and on the lingual aspect of every one of the implants. With the idea, if I'm doing significant TMJ therapy, where we're actually treating not only the joint, but the lymphatics, that's going to be significantly longer. But it's usually somewhere in the neighborhood of about 30 seconds to a minute per site, depending on the device you're using, depending on the power of the device you're using, and the wavelength. So photobiomodulation is very much device-specific dependent. With the idea, if you're using it in a continuous wave mode, your treatment time is going to be significantly less, but there's going to be a little bit more heat buildup within the tissue and the device itself. Using it in a pulsing mode, you may need to do a longer treatment time because the laser is only firing at incremental situations in that way. The next question is that I've gotten here, which is a very intriguing one. Can it be used on extraoral wounds? And the answer is yes. It was formulated specifically for the oral cavity. My wife actually had caught the side of her arm on a striker plate for a door and made this a really long gash down her arm. And the only thing I had in my house to treat it with was the socket gel. I applied it to the wound and then bandaged it up, and the thing actually had healed without even a scar. I thought for sure she was going to have a scar, and going about it that way. And so it's a matter of it can be used anywhere in the body that you want to use it. It's formulated to basically be used in the mouth. There are similar things, I believe, that are available. The Kerosene gel is one that you can get, I believe, on through Amazon. That is basically an extraoral equivalent to the socket gel. It's called Kerosene ointment, and doing it that way. So again, that's the answer to that question. So yes, it can be. And why you do it that way? One of the questions is, do I have a recommendation for a laser? And the answer is, the appropriate laser depends on the procedure you're trying to perform, with the idea that there are lasers that are designed very specifically for photobiomodulation, things like the Thor laser, the Sumus lasers. They've been designed very specifically for photobiomodulation. Some of our intraoral surgical lasers also have photobiomodulation wands that go with it. One of the ones I'm using is a 660 that has an 8mm probe on the end of that. Looks like an old-fashioned curing light that we're applying from the buccolingual aspect, and it attaches to a battery-operated surgical laser that I have, and we're using that for photobiomodulation because it's simple, easy, and quick to be used. Another question that I've received here is this approved to be used in Canada? And the answer is yes, it's approved. It's normally available in Canada through National Dental, as well as Shine and Patterson, I believe. I'm not sure if St. Clair is carrying it, but I do know it's available through Patterson and Shine in Canada. It's being distributed today by the Septodont company. So I would imagine any place that any of the dealers that carry the Septodont products would actually have access to the socket gel itself. And what about on a suture or oil alone? With the idea that whenever I'm suturing anything up means I have an open wound, I always apply the gel to it. And again, very often we will apply photobiomodulation, ideally before and again afterwards. Sometimes due to the nature of what we've done in the surgery, that the post-operative intraoral treatment with photobiomodulation is not really advantageous or easy to acquire at that time. But with all of our surgical cases, we like to pre-treat with our patients before we start the treatment. And when you're getting into photobiomodulation, develop a workflow. Photobiomodulation devices can be bought for, over the counter for home use. In my office, the PBM is being administered by my auxiliaries in the office. We have a rule: whoever seats the patient is the one that's applying the appropriate PBM treatment. So we haven't had to add any time at all to our appointment. And the person who's giving the post-op instructions, while they're giving the post-op instructions, they're applying the photobiomodulation in the cases where we're doing it post-operatively. And another question that has been just thrown at me was about allergies. The only allergy that I'm aware of is the cinnamon oil allergy, and I would not recommend the use of the socket gel in that type of an environment. But always be sensitive, and always tell patients with everything, if you feel like you're having a reaction to it, discontinue use and let us know. And no matter what we're doing, and going about it. The products that we were talking about today was the OraSoothe and the Socket Gel, and I think I've already talked about that as through normal dental distribution channels. As I mentioned, it's being distributed now by the Septodont company and things along that line. Have you heard of Stella Life Oragel? Yeah, I have. It doesn't have the same type of composition as the socket gel, which is why I've found a better result with that, which is why that is the type of what I'm using now routinely, and that's basically the only intraoral medication as far as a topical ointment that we're applying, all other than obviously fluoride for caries, but that's a completely different topic all by itself. Another question, have I found that applying the gel, it's disrupted the sutures? And the answer is no. And again, depending on how fragile the tissue is, we in turn will tell the patient to lightly place it over it and use a patting action rather than a swirling action for that. The mouth rinse works very well when normally with especially our scaling and root planing patients, the diagnostic appointment is where we recommend that to be used to help control the inflammatory response before we actually get into the SRP, and then we in turn dispense the socket gel from the office. If there's a downside to both of those, they're only able to be dispensed from the office at the present time, and going about it that way. And I had a question that was asked, from somebody about the photobiomodulation. How many joules per centimeter squared do we apply? And it depends on where my target tissue is. With the ideally, we want to have 4 to 8 millijoules per centimeter squared applied to the target tissue, but it depends on how deep it is. And again, how much of that energy is going to be absorbed before it gets to the target tissue. So it's understanding the device you have, and will it reach the tissue. When I teach my laser courses, I really am emphatic on the 3 basic principles. What is my treatment objective, and what am I trying to accomplish? Second, where is the target tissue, and what is the composition of the target tissue? And then I will then think about what is the right type of light energy to achieve my goals. What's the appropriate wavelength? We know that a 660 LED will not penetrate as deep as an A10 or a 1064 laser. And so if I'm looking for deep tissue response, I'm going to use something along that line. If I'm looking just to treat the inflammatory response on the surface, I'm going to use something in the 660 line and do it that way. As understanding the penetration of your light energy becomes very, very, very important. And we use the same amount of energy both preoperatively and postoperatively because our target tissue is the same in both of those cases. And with the idea of another question that has been asked to me was, what is the pricing of the photobiomodulation devices? And they range all over the place. The granddaddy of them all is the Thor laser, that the complete system with various probes and everything else can run in the neighborhood of $20,000. There's some that are even more expensive. They actually have photobiomodulation beds that are available now that are being used for systemic health and things along that line. So many of your surgical lasers that are available today will have a photobiomodulation wand available to go with it also. The disadvantages of having the photobiomodulation wand as part of your surgical laser is the fact that it only can be in one room at a time. The advantage of it is if it's part of the laser that you're already using, you have the same piece of technology available. Workflow, it becomes very, very critical as we get into more and more advanced technologies. So that's very important, and going about it from that point of view. How much would you add to the bone substitute? We actually mix it up into a gel or a putty, and then use that as part of the packing with our particulate matter. I've gotten better results with that than I have with anything else, of even platelet-rich protein and a variety of things along that line. I stopped using all of those personally because I found I was getting better results and all of that. OraSoothe and Socket Gel are one and the same. OraSoothe, there's OraSoothe Rinse, and OraSoothe Socket Gel is a gel. The chemical composition is basically the same between the two of them. The difference is one is a gel and one is a rinse to be swished around. And depending on what we're treating, we may tell the patient to swallow it, especially if the patient has a fungal infection. We're trying to treat candidiasis. I want to treat the entire pharynx all the way down. So we tell the patient to swish it around and swallow it. With the idea, one of the last questions we got here was, how well do medically compromised patients respond to this technique? Well, medically compromised patients respond extremely well to photobiomodulation. Because of I'll call it the astringent nature of the OraSoothe and the Socket Gel, we find that people that have oral mucositis, that until it gets under control, is something that the patients may find a little bit irritating. But patients that are medically compromised, one of the beauties of light therapy, whether it's surgical and or photobiomodulation, is the fact that we in turn can treat patients that are medically compromised with the least amount of complications. I don't take my patients off their blood thinners for anything I do today, because with the lasers I have in my office, even when I'm doing a surgical technique, I've got the ability to control the hemostasis. So with that, our hour is up. How's that for perfect timing? I want to thank you all for attending. The people at Viva Learning are going to interject and tell you how to get your CE credits for that. My contact information is on the screen. Do not hesitate to reach out to me. I'm always willing to talk to our fellow colleagues. We learn from each other as professionals. Sharing knowledge is something that's very important. Sharing concerns is also very important. So thank you all for attending, and